Very good morning to everyone who's joined us today. Today's lecture is going to be on approach to a patient with end-stage COPD. And to present this, we have with us Dr. Pooja Dutta, and this will be moderated by Dr. Amina Mobashir. A very warm welcome to the both of you. And I now invite Dr. Gaurav to please introduce our speaker and moderator for the day.
Yes, good morning. Good morning.
Good morning. Yes.
So,
Can you please introduce the speaker? Yeah.
Dr. Pooja is a first-year resident in DNB Palliative Medicine at Max Super Specialty Hospital, Saket, and she'll be presenting on the topic of approaching a patient of COPD. And Dr. Amina is consultant in the Department of Pulmonology at Max Super Specialty Hospital, and she is very keen for the topic, and her other areas of interest are interventional pulmonology, sleep disorders, critical care, and allergy and immunology.
Good morning.
Morning, ma'am.
Thank you, Dr. Gaurav. Dr. Pooja? You are muted. Yeah, you can present now. Thank you. Welcome, Dr. Amina.
Good morning, everyone. Myself, Dr. Pooja, a first-year resident in Pain and Palliative Care Max Super Specialty Hospital. And today my topic is approach to a patient with end-stage COPD. Next slide. To begin with breathlessness, being floored by something that has just robbed me of everything, basically, and that not even having the breath to sometimes even be able to scream, get the frustration, or even to explain what is happening to me because I can't speak. Next slide. We'll start with a case. Here is a patient by name Rajendra Kumar, 59 years old male, a resident of Sainik Farms, Delhi, shopkeeper by occupation. Patient had complaints of breathlessness since 2 months, which are so severe that it hampered his activities of daily living and was not relieved even after taking rest, for which he required hospitalization. He also had complaints of breathlessness on exertion since past 10 years, but it has progressed since past 2 months. Patient also had complaints of cough since past 1 month associated with sputum that is scanty in amount, white in color, mucoid in consistency, not blood tinged and non-foul smelling. Next slide. Patient had no history of orthopnea, bilateral visible swelling, or no history of weight loss, no history of loss of appetite, no history of hemoptysis or chest pain or palpitations, no history of heartburn or epigastric pain, no known allergies, and no history of COVID-19. Next one. In the past history, he had shortness of breath and cough.
Dr. Pooja, you muted.
His symptoms was exaggerated for the last 2 months, for which he required 2 hospitalizations, where the patient was managed by oxygen support, IV antibiotics, IV steroids, nebulizations, and NIV. Other comorbidities, he had no such comorbidities like hypertension or diabetes or pulmonary TB, and the patient was on occasional MDIs for the last 1 year. Next slide. Coming to the family history, he had no similar complaints in the family and no history of asthma in the family. Personal history, his diet was mixed, appetite normal, sleep adequate, bowel and bladder normal and regular. Coming to the substance use, an ex-smoker, he had quit smoking since last 6 years, and the pack years when he was doing it was 70 and the smoking index was 1400. He was a quite heavy smoker. Next slide, please. Coming to the examination part, his appearance, he was a thin build with slightly stooped posture and a barrel-shaped chest. He was awake, conscious, oriented to time, place, and person. Using accessory muscles on percussion, it was hyper-resonant, and the bilateral air entry was present, and there was some waste present. Investigations at the time of admission, his TLC count was 17,500. Coming to the X-ray, it shows hyperinflated lung fields with bilateral prominent bronchovascular markings. On 2D echo, the RVSV was 44 mmHg, and in PFT, we could see obstructive airway disease, and on the initial ABG, it was type 2 respiratory failure. Next slide. So, coming to that, this is a typical history in every COPD patient. Repeated exacerbations, repeated hospitalizations, repeated ICU admissions, and sometimes even maybe required assisted ventilation, including caregiver stress, distress, and no assessment of symptom burden, no discussions on advanced care directives. Next slide. In this picture, we are seeing the illness trajectory, which has frequent or repeated exacerbations, and with each one having the risk of sudden death. Next slide. An overview of today's talk. We are going to speak on COPD, definition, etiologies, clinical features, diagnostic criteria, integrated assessment tools, comprehensive approach with palliative care, prognostic index in COPD, and approach for the management of COPD, integration of palliative care in COPD, the referral criteria for palliative care or hospice care, the barriers involved in palliative care, and the outcomes of palliative integration, ending with conclusion. Next slide. In COPD in brief, we are going to speak on definition, risk factors, clinical features, investigations, diagnosis, and treatment. Next slide. Definition of COPD. According to the latest polled COPD 2023 update, it's a heterogeneous lung condition characterized by chronic respiratory symptoms, dyspnea, sputum, production and or exacerbations due to abnormalities either of two things, either airways, that is bronchitis or bronchiolitis, and or alveoli, that is emphysema, that cause persistent, often progressive airflow obstruction. Next slide. Coming to the risk factors, it includes cigarette smoking, biomass exposure, occupational exposure like organic and inorganic dust, chemical agents and fumes, air pollution, SERPINA1 gene mutation causing alpha-1 antitrypsin deficiency, asthma and airway hyperreactivity, chronic bronchitis, infections like Pseudomonas aeruginosa, and it is more in males compared to females, and socioeconomic status. Next slide. This is the new proposed taxonomy for COPD in latest Goal 2023 update. So according to this, we have different types of COPD categorized into genetically determined, first one, and where it is mainly due to alpha-1 antitrypsin deficiency. And the next is COPD due to abnormal lung development, which includes premature birth and low birth weight. Coming to environmental COPD, it includes cigarette smoking and biomass and pollution exposure. In cigarette smoking, we include tobacco smoke in utero or even via passive smoking, even the use of e-cigarettes and cannabis. The biomass exposure is mainly due to household pollution, ambient air pollution, wildfire smoke, and occupational hazards. COPD due to infections is mainly tuberculosis associated and HIV associated infections. COPD and asthma correlated is particularly the childhood asthma. Next slide. Clinical features as such in any typical COPD patient is shortness of breath, chronic cough with sputum production, episodes of acute exacerbation, chest pain, muscle wasting and cachexia, sexual dysfunction, sleep disturbance, and fatigue. Next slide. Extrapulmonary manifestations of COPD, coming to skeletal muscle dystrophy, usually they present with muscle atrophy and muscle weakness. Osteoporosis, almost 35 to 70% of patients are reported to be osteopenic, and around 60% patients with osteoporosis. Coming to cardiac manifestations, we have few shared risk factors for both cardiac manifestations as well as COPD, like advancing age, cigarette smoking, and air pollution. And for every 10% decrease in FEV1, the all-cause mortality increases by 14%, and the cardiovascular mortality increases by 28%. Also, in patients with COPD, arrhythmia may be associated with high mortality. which has atrial fibrillation and ventricular arrhythmias. Cachexia is excessive weight loss with disproportionate muscle wasting, and it increases with severity of the disease. To speak on depression, in COPD patients, mainly because of dyspnea, the patients are bound to be immobilized and lack of fitness, leading to social isolation, which end up in anxiety and depression. Coming to cancer, COPD acts as a risk factor for development of cancer, mainly due to impaired mucociliary clearance, genetic predisposition, oxidative stress-mediated inflammation, and carcinogenic process. Next slide. Diagnostic criteria according to the latest goal 2023. A diagnosis of COPD could be considered in any patient who has dyspnea, chronic cough or sputum production, and history of exposure to the risk factors discussed earlier, including but a forced spirometry that demonstrates the presence of post-bronchodilator FEV1 by FVC less than 0.7 is mandatory to establish this diagnosis of COPD. We then have types called pre-COPD and PRISM. The pre-COPD is mainly a variety which has respiratory symptoms with structural lung lesions and abnormal FEV1 values but without any airflow obstruction. Whereas PRISM stands for preserved ratio of FEV1 by FVC but impaired spirometry of less than 80%. Next one. Next slide. Based on the severity of airflow obstruction, we have classification of COPD using GOLD, that is into 4 types. GOLD type 1, 2, 3, 4 is mild, moderate, severe, and very severe, where we decided on FEV1 value of more than or equal to 80%, and moderate is 50 to 80, and severe is 32, less than 50% predicted, and very severe is less than 30%. Coming to the Modified Medical Research Council dyspnea scale, which has grades 0 to 4, and grade 0 is breathlessness with strenuous exercise. Grade 1 is shortness of breath with hurrying on a level or walking slightly uphill. Grade 2 is walking slower due to breathlessness or have to stop for breath while walking. Grade 3 is feeling breathless after a walk of 100 meters or after a few minutes of walk. Coming to grade 4, it is breathlessness at rest or can't leave the house because of breathlessness. And we are discussing this for coming to the next AB assessment tool. Next slide. CAT assessment, it stands for COPD assessment test. It has a scoring from 0 to 5. Starting from 0 is the better and 5 is worse. It includes features like I never cough to I cough all the time. I have no film in my chest at all. To my chest is filled with complete film. My chest doesn't feel tight. I can walk up a hill. I don't feel breathless. I'm not limited at home to doing any activities. Coming to the worst part is I'm limited along doing the activities at home. I'm confident leaving my house despite my lung condition. But here the worst condition could be I'm not at all confident leaving my house because I have the lung condition. I sleep soundly. I can't sleep soundly because of the lung condition. I have lots of energy and I have no energy at all. Next slide. We then have the ABCD assessment tool, which in the new gold update has been changed, categorized into ABE, where E is the club version of the previous C and D. So E mainly includes more than or equal to 2 moderate exacerbations, or more than 1 or equal to 1, which is ending up in hospitalization of patient. Could be considering as an end-stage COPD also. Next slide. To describe end-stage COPD, it is mainly gold stage 3 and 4, that is FEV1 30 to 50% predicted or less than 30% predicted. 2 flare-ups in the last 1 year and more than 1 hospitalization. Next slide. How we can discuss on 2 different things, that is COPD focused assessment and one more is COPD palliative care assessment. Usually the COPD focused assessment done by the pulmonologist would be mainly focused on respiratory symptoms, exposures, tobacco use, vaccinations, spirometry, CT scan, supplemental oxygen evaluation or pulmonary rehab. They focus mainly on the comorbidities like coronary artery disease, pulmonary hypertension, heart failure. Coming to the directed therapies, it would be oral medications, inhalers, or advanced therapies is NIV, lung transplant, or lung volume reduction surgery. Whereas if we go with the comprehensive COPD palliative care assessment, it would look for a broader physical symptoms, including pain, refractory breathlessness, cough, looking for the emotional status, HADS and PHQ-9 questionnaire. HADS is hospital-acquired anxiety and distress scale. And we even focus on the nutrition part, the unintentional weight loss, uh, the spiritual needs, social support, the family and the caregiver needs. Coming to a broader evaluation of multimorbidity, including the psychiatric conditions in COPD patients, the broader assessment of medications, including the use of opioids like morphine in smaller doses for respiratory distress, antidepressant, anxiolytics, coming to evaluation of home-based palliative care, the physical and occupational therapy. Uh, Coming to the prognosis part, we even make sure to have a values-based discussions to discuss on the advanced directives, living will, and surrogate decision maker, including even respite and bereavement care needs. Thank you. Please next slide. Board index, it's a prognostic tool in COPD, mainly for calculating the risk of death in COPD. So it has four components. One is body weight index, degree of airway obstruction, dyspnea, and exercise capacity, which is measured by the 6-minute walk distance. Next slide. We use, next slide. The variables we use mainly for these four components is FEV1, the distance walked in 6 minutes, the MMRC dyspnea scale, and the BMI. We usually give points from 0, 1, 2, 3, and any board index of above 7 is a worse condition. Next slide. Coming to the disease management part, the non-pharmacological interventions in COPD would be smoking cessation, regular exercise and physical activities, pulmonary rehabilitation, influenza, and pneumococcal vaccination. According to the gold new update, even the zoster vaccination is included, and with focusing on high protein diet. Next slide. Pharmacological interventions mainly include the drugs commonly used are bronchodilators, steroids, opioids, benzodiazepines, mucolytics, and cough suppressants. Coming to speak on commonly used maintenance medications in COPD, we use beta-2 agonist, short-acting and long-acting. Short-acting like salbutamol or dibutylin. Long-acting is salmeterol or formoterol. Anticholinergic starting with the short-acting ipratropium bromide. Long-acting as tiotropium bromide or glycopyrrolate. Methylxanthines, aminophylline, theophylline, mucolytic agents like carbocysteine or N-acetylcysteine. Coming to the invasive strategies, we have supplement oxygen, and long-term oxygen therapy is mainly used for hypoxemic patients in the last end stage of COPDs. Use of BiPAP, and lastly, lung volume reduction surgery and lung replacement. Next slide, please. Coming to speak on pulmonary rehabilitation and education and self-management, it mainly includes a range of healthcare professionals, and we mainly focus on as careful assessment. We discuss the patient's goals, the smoking status, nutritional health, the health literacy, the social circumstances, comorbidities, also the exercise capabilities and limitations. The 6-minute walking distance test and shuttle walking test to be in use in everyday routine. According to the King's College and the Cambridge College, there are few interventions for breathlessness services, which mainly focus on the where the palliative care physician would mainly ask on the experience of breathlessness, and they would make the use of information leaflets, which would include a poem or a chart or showing the different positions of which can make ease for the patient in times of breathlessness. Also can a use of handheld fan, water spray, focusing on the sleep hygiene, brief cognitive therapy, the well-being interventions, mindfulness CDs, any other resilience building options. Next slide, please. Now coming to integration of palliative care in COPD. Okay, here in this picture, we would speak on in the red line. Mainly, it shows the COPD patients with repeated exacerbations, and with every time each exacerbation, it holds the risk of sudden death. In the initial status, it is usually the disease-directed therapy. Towards the end, it is to bereavement and respite care. The blue dotted line is mainly patients with cancer and idiopathic pulmonary fibrosis, who also the well-being of them towards the end of their life, it is worsening. And historically, we have this late palliative care involvement towards almost near to the death, where it's not helpful, and it's towards like the worsening of a patient's well-being or deprivation in stages of bereavement care. Whereas the gray line showing the early palliative care involvement, it would help in decreased hospitalizations, exacerbations are lesser. The bereavement of the patient and the family is also taken care well if palliative care is involved in the early stages of COPD patients. Next slide, please. In this picture, we would speak on 4 different levers or potential triggers for initiating palliative care. The first one, mainly based on the lung function, that we would see by gold stages, that is any gold stage 2 or above, from FEV1 50% to 80% or the other. Coming to the second one, we would focus in patients with refractory breathlessness, unintentional weight loss, declining functional status, or high burden of caregiver needs. The third level is poor prognosis, and that we can measure by board index value of above 7. And the fourth one or more than one severe exacerbations. So these are the 4 different levels, and any of the institutional policies can be based on these levels, like the respiratory physician and palliative care physician can come to a consensus taking the above. Next slide, please. This was a survey done in Netherlands in a setting of COPD patients, mainly looking for how palliative care can be integrated, and they were looking on that. And this is a survey done by pulmonologists and general practitioners, and they have come up with the triggers for palliative care integration, and those are mainly as follows. It's mainly based on the symptoms. So it has been given a clinical expertise and asking the surprise question, even according to gold classification, and using clinical indicators. Next slide, please. The potential models for palliative care integration, it would mainly be 4 types I could speak. Symptom triggered services, where if a patient is having refractory breathlessness, then that can be considered. The second is a short-term integrated palliative care model, where breathlessness support service can be given. Advanced COPD clinics, including both the pulmonologist and the palliative care physician. And then lastly, the integrated respiratory care services. So we can speak in detail about the pulmonary rehab, early supported discharges from the hospital, and home-based palliative care. Next slide, please. These are the few referral criteria we can see for an hospice care also, since hospice care is a part of the palliative care. So the criteria should be in cases of very severe airflow obstruction, breathlessness at rest, or refractory breathlessness coming up with a hypercapnia or dependence on oral steroids, frequent exacerbations, unintentional weight loss. Next slide, please. This is according to a national consensus project where we are speaking on different domains of palliative care, and it is mainly 8 domains we are going to speak. First one is structure and process of care. The second one is physical aspects of care, which mainly focus on nebulization, inhalers, symptom assessment, coming to initiate the fan therapy or low dose opioids, and evaluate the impact of multimorbidities, including given to initiate look for the functional status, home health or occupational therapy, asking even to assess the frailty, sarcopenia, cachexia, and malnutrition. The third domain mainly focuses on psychiatric and psychological aspects of care, where we can measure the anxiety and depressive symptoms of a COPD patient. We can counsel, and we can even offer them music therapy and pet therapy. We can consider anxiolytis or antidepressants. We can even measure the cognitive impairment. This is about the third domain. Coming to the fourth domain, that is social aspects of a COPD patient. It would be mainly the social determinants of health, screen for social isolation in case of COPD patients. Coming to the fifth domain, it speaks on spiritual, religious, and existential aspects of care. We are supposed to address the spiritual care needs of the patient. We are supposed to understand the culture the person has been from the beginning, and give importance for it in the end of life care. So the sixth domain was cultural aspects of care, where we can ensure palliative care access for the patients. Coming to the seventh domain, it is care of the patient nearing the end of life. Where this mainly we can discuss by asking the surprise question, or we can use the board index as a prognostic tool, so that we can engage the partners and the family members. We can do family meetings and we can come up to the conversations of advanced care planning or the end of life care planning. And the last domain is ethical and legal aspects of care, where we would basically go and speak on bereavement or survivorship needs. Next slide, please. Coming to speak on the barriers in integrating palliative care. This was again the survey done by Netherlands in August 2019 for an overview of palliative care integration. So the main barriers in integrating palliative care is difficulty of predicting the disease course, the lack of clear definition of palliative phase in COPD, patients having the difficulty of specifying what the future would look like, and even the lack of time. Next slide, please. Before I would end, I would conclude by saying this is what we can gain out of an integrated approach of palliative care. Mainly, we will assess and manage the symptoms and concerns. We would plan for end of life care. We would provide education about the illness and prognosis. We could bring the families and patients together and building relationships with the patients and the families. Mainly, we could focus on the dignity and the self-worth of the COPD patient and improving the disease, understanding of the disease with the patient, giving them opportunity to face the complex issues collaboratively, and even including them to avoid the last stage admissions in the hospital. The outcomes would definitely be an increased or better quality of life, decreased symptom burden, decreased hospitalization, and an increased patient and caregiver satisfaction. Next slide, please. Conclusion. Coming to a conclusion, it is patients with COPD hospitalized with an exacerbation are confronted with a life-threatening illness and severe symptom burden. So there's a need of palliative care integration for with the respiratory care, as multi-component palliative care interventions are available, which can improve the outcomes for patients, loved ones, and may reduce healthcare use. We can look up for the admissions of COPD with trigger points to initiate palliative care, including advanced care planning and palliative treatment for breathlessness. I would like to say not to forget to audit your services and improve your services with time. Thank you for patiently listening. Thank you all.
Any questions? We can proceed. Dr. Pooja is here. Dr. Amina is here.
So am I audible, Dr. Gaurav?
Yes, ma'am.
Okay, so I have a couple of comments just to sum what Pooja has compiled so brilliantly. So one, of course, in her last slides, she did mention that end-stage COPD should not just be dependent on, the diagnosis of an end-stage COPD should not just be focused on the spirometry values or the number of exacerbations. The functional assessment of a patient is very, very important in terms of whether the patient is on LTOT, largely restricted to his bed, on an IV, whether the patient is emaciated, low serum albumin, how much is the 6 minutes walk distance, and what are the comorbidities. Also, a very interesting fact which I came across while, reading about this palliative care, which is very useful for me also, is that most of us are very wary of using morphine in COPD patients because we have this, I would say, this edged in our minds that morphine would lead to elevated levels of CO2. However, there was a recent paper which was released by the ERS, which says that the difference in the CO2 levels in a patient on morphine or on placebo was just to the tunes of 1.5 to 2 mmHg, which is not like really significant. And if it causes the patient some benefit in terms of, the breathlessness part, then it's really worth it. The third thing, of course, which is very important is the psychosocial support. But, before one last perspective as a pulmonologist is that, of course, an end-stage COPD patient does need palliative care at some point or the other. And it is important for us to recognize those triggers. But we should also, first check whether we are giving the patient an appropriate treatment as well. Suboptimal treatment should be, corrected, and infections should be prevented by giving appropriate vaccinations. And despite that, if the patient is progressively worsening, is falling into the category of end-stage COPD, then it is absolutely worth while calling in the palliative medicine help and holistically treating the patient.
Absolutely, absolutely. And what interesting, I mean, if somebody has a, breathlessness service or a support care service, especially for COPD, I mean, if somebody wants to share their experience of such a service, I mean, it would be great.
Thank you, everyone. Yeah, I just want to share that we have Dr. Naveen Salins with us today. Welcome, sir. Would you like to share some comments? Yeah.
Hi, Archana. Thanks, Gaurav, for your comments. Yeah. So I'm just filling in. Madam is not there. So most of the places would not have a specific breathlessness service dedicated for a COPD. However, those who are working in a multi-speciality hospital like ours would see COPD patients when referred by pulmonologists. So it may not be possible, unlike in the West, where they have very COPD specific breathlessness service. Thanks, Dr. Pooja, for making this presentation. If there are any other questions, you can ask Dr. Pooja or Dr. Amina or Dr. Gaurav.
Can I make a comment, Dr. Nandini here?
Sure, ma'am.
Yeah, so we work at a multi-speciality medical college hospital that's similar to, so then one thing we need to remember is that our clients are patients as well as the specialists. So as we are treating the patient, that feedback has to happen to the specialist also. So they see the impact, they see the improvement in comfort. And so then comes the other references. So we are quite now well integrated with the pulmonology department. So we do get interstitial lung disease and COPD references. Even around the decision-making time, prior to shifting the patient to ICU, etc., when there are repeated admissions. So this is an important part which we need to remember. The integration happens when we communicate, and very often we manage the patients within the pulmonology ward and not shift the patient. Another thing is the skills that we need to manage pulmonology can be beyond the pharmacological aspects. Of course, with a multidisciplinary team, we need physiotherapist inputs, and everyone knows about the psychological and medical social workers inputs. Besides that, we also need to update about handling a BiPAP machine, HFNO, and also have the NGO database from the region. For example, in Bangalore, we have created a database of who will be renting a hospital bed so that they can go home and have a propped up position, or the BiPAP machine, how much would it cost, oxygen concentrator, and the handheld fan. Of course, you don't have to have the fancy electronic versions, the battery-led ones. You can also have, in simple families, they can do it actually a hand fan. And then you can demonstrate these while they are in the inpatient departments. So they understand the value of it, so to the spray to the face of the little water and then fanning, and how they can feel better. So the family education and involvement is huge while they are in the inpatient settings. Then the care at home becomes, of higher quality. So three levels of integration is, of course, in our own department, a little more knowledge about pulmonology within the interaction of us with the specialist. And third, the family caregivers who are absolutely prime in maintaining the continuity beyond. And of course, extending home care so that they are reinforced and they are supported while they are at home.
Absolutely, golden words by Dr. Nandini. I think this is the way we can also say that in the various levels of integrations of palliative care into pulmonology. Ultimately,
Gaurav, I just want to make one comment with what Dr. Nandini has mentioned. In UK, there was one startup company. So I'm part of a project called as Breathe India project. We're doing some research on breathlessness in India. And in UK, a startup company had made a handheld fan, and I had seen that. It is absolutely inexpensive thing. And now there are a lot of studies that are happening using that handheld fan that has been developed. It is very lightweight, portable. Patients can carry it in their pocket actually and use it. And it's like it's smaller than a smartphone, and there are no blades, and there is a gush of air coming from that. If that product becomes successful, that is something that everybody could use it even in India. Maybe if they don't patent it and allow it for an open replication of the same.
Naveen, what we do is, we do have something which costs in few hundreds, like, 300-400 we get hand fan here, but
Yes,
that
ma'am.
also sometimes becomes costly for
Yes.
certain category of patients. So what we do is we keep, we have 2 handheld fans as part of the department equipments so that they understand what is the purpose of it. So we demonstrate while they are inpatient, the family understands. And then if they are able to buy, we show the Amazon link. Otherwise, we just say that you can use a newspaper or any simple, the South India and North India, all of them have those old style, simple hand fans that also
ma'am.
someone else is there. So very right. It's a simple technique, but it is highly effective. And especially when we can give control to the patient that certain things that you do, a sublingual or azepam or, 2.5 morphine along with the spray on the face and handheld fan can break that cycle, vicious cycle of breathlessness, anxiety. They get that sense of control. And then they go back home more confident of handling their episodes. Thanks.
Yes. And also, just to add on a couple of things, because as part of this research, a lot of this intervention, what you read, non-pharmacological intervention in the textbooks or from the literature, are from the West. And some of them, if you look at the acceptability among the Indian population about this intervention, because we have our own set of health beliefs. And sometimes our set of health beliefs, which are very culturally situated, could sometimes conflict with the evidence. So that's something that also we have to take a look at. And that's another work that we are also looking at, how prevailing health beliefs could be a conflict with the current evidence. Just as an afterthought. Dr. Meenakshi has raised her hand. Go ahead, madam.
Sir, good morning, sir. Good morning, Dr. Nandi, and thank you for the presentation, Dr. Pooja, Dr. Amina, Dr. Gaurav. I wanted to just raise one question rather than more than a question. It is a comment. Can you elaborate as a pulmonologist when confronted with a COPD patient and who is opioid naive? How much will you start? When will you titrate the morphine, and to what is the maximum level you would go to?
Okay, that's a very relevant question, Dr. Meenakshi, and thank you very much. But to be honest, we have actually never never given. So like I was mentioning in my comments also, that we are very scared of giving a COPD patient, particularly in those who are in the end stage COPD, who have type 2 respiratory failure. So we've always been very scared of giving them morphine. So if you ask me, in my clinical practice, I have never given morphine to any patient who is an end stage COPD. We go with zolpidem, in some cases clonazepam, with minimal respiratory depression, as we've been conventionally taught. But only during, preparing for this presentation with Pooja, I went through some more records and realized that morphine after
So I
this
will,
was more.
I will interrupt that we are using morphine for our patients in oncology where we have COPD and lung cancer, and so that is why I was just talking about that. That breathlessness service is an important aspect when you look in terms of you have to manage a respiratory failure or breathlessness when you are sending the patient home or your patient is in ward, and maybe sometimes there is a shared decision making of goals that you are using non-invasive ventilation or sometimes you are not using non-invasive ventilation. So you start depending on the condition of the patient. Orally is the preferred route. We start with 2.5 milligram like Dr. Nandini mentioned. So it is difficult to make 2.5. 10 milligram is the lowest tablet which is available. So half of the tablet to be diluted in water and given half of it. So this is how we start, and we start with maybe 6 to 8 hourly initially, or mostly the night dose. Sometimes, if the issues are mostly uh, that early morning awakenings with breathlessness and inability to sustain sleep for during the night time, and gradually we increases the dose. And sometimes the patient is already on morphine because of the cancer related pain. Then we obviously have to titrate morphine based on both pain and the breathlessness which patient is having. Very few cases we have, when we are integrating very late, we start with IV morphine when we are in a position where patient would not be able to sustain oral morphine for a very long period of time, or the patient is has expressed wishes and is going home and not has a very lucid time and oral intake is very poor. So then we also initiate IV morphine.
Thank you, Dr. Gaurav. Ma'am, Dr. Nandini, Dr. Naveen said, would you like to add to this? I mean, you're in a multi-specialty hospital. What is your experience?
Yeah, surely, Meenakshi. So, as Gaurav said, it is available, morphine is available as 10 mg. So there are two ways of doing it. In our hospital, instead of using, this is something that we learned. Instead of using water, if you use saline to dilute this 10 milligram tablet, so you just put the tablet in a 2 cc syringe and put saline in it, it dissolves just like that. Because in water, it doesn't dissolve well. It's like, little bit you have to crush and it doesn't come uniformly. This is like immediately it dissolves. So you make it into 4 cc if there is, to be done in a hurry. If it is not required in a hurry and we have time, we have got this agreement with pharmacy. So we write a note to powder the tablet and they make sachets of 2.5 and we get ready, they make it, by weight and they give it to us and of course to the patient and we use it in that manner. So that is the way to do it. And when we are using, so second comment is on, suppose the patient is already on pain medications with morphine. What we do is, suppose the patient is, say, 10 milligram as a regular dose, 25% of the dose is added. So that means patient starts getting 12.5. If the patient is at 20 milligram, they will get 25 milligrams. So add 25% of the analgesic dose, and then that becomes an additional dose for pain plus breathlessness. Third thing is about the clinic. As Gaurav mentioned, it may be in current Indian scenario, having a clinic just for breathlessness may be superfluous because space is premium. So what we have attempted is we have the support, like we have palliative care OPD in the oncology block. So most patients on OPD reference, even from pulmonology, neurology, nephrology, and all, have to come to the oncology block, which is not, of course, it is a little bit distance. But now, because of the presence in the inpatient care, the departments and the number of patients being integrated are more. We are starting a supportive care clinic in the super specialty OPD area itself. So it is not specific to pulmonology. It is for anyone from the, nephrology or neurology, gastro, hemat or pulmonology to refer to. So there is one area for palliative care where everyone is familiar, but there is also supportive care so that there is little more earlier referrals. So all these are different ways in which we could integrate better.
Ma'am, you got muted.
Did you all hear about the supportive care OPD when I said?
Yes,
Yes.
ma'am. Yes, ma'am.
Yeah, so that is all. My comment ended there. Thank you.
Thank you, ma'am.
So I think the challenge would
So Dr. Stanley's hand is up. Can you please give your comments, sir?
Thank you. Sorry for joining late, so I hope I'm not repeating something, but just want to share an experience that, the pink puffers, the people with emphysema, predominant emphysema, with slightest exertion, they are, very breathless, they are puffing away. And these kind of patients, I found that a small dose of morphine 2.5, and slowly titrating that, helps them to cope better with that breathlessness. They are able to live their life a little more, easily without getting too breathless all the time. So that is one. And regarding the getting people early, for supportive kind of care for COPD, what we have tried to do is to have what we call a combined clinic on a half day. So we give half an hour slot for everybody, and they can bring their patient who they feel could benefit from this, and together we can see those patients. So that has helped to bring them early, to benefit from these kind of things. So it's not only COPD, it's all different things, specialties. We give them half an hour slots, and they bring 1 or 2 patients, and they can benefit from that. Thank you.
Thank you, Stanley, sir. So I think the challenge is both at the OPD level to manage breathlessness, and sometimes when the patients are in the terminal stages, in the ward and on respiratory failure, these two areas would require special attention whenever you are managing COPD patients.
So if there are no other questions, we'll bring this session to a close. Next Monday, there won't be a Monday morning teaching due to Ganesh Chaturthi festival. So the next session would be the Monday after the next Monday. Thank you everyone for joining this morning. Thank you.
Thank you, sir.
Thank
Thank you.
you, everyone.